Lateral humeral condyle fractures are the second most common fracture in children. They account for 16 to 20% of all distal humerus fractures. And if they're non-displaced or minimally displaced, they may be treated appropriately in a long arm cast. These patients then need to undergo close follow-up to monitor for any subsequent displacement in case they end up needing operative intervention. This has been reported to occur between 1 and 15% of the time, but the problem is that there's been no definition of what close follow-up is, leading to a lot of variability in cast changes, x-rays, and number of visits these children undergo. Value-based care, I think we already heard from a little bit this morning, but it's a really hot topic right now, not just in orthopedics, but medicine in general. It is influencing policy, insurance reimbursements, and it's all over healthcare. It involves paying for healthcare services in a way that directly links performance to cost, quality, and the patient experience, and aims to minimize waste, which the Center for Medicare and Medicaid has defined as the overutilization of services or practices that result in unnecessary costs to the healthcare system. So with this in mind, we sought to look at all of the non-operatively treated lateral humeral condyle fractures in a large tertiary center. We wanted to see what the actual risk of displacement was because it is so widely variable in the literature, and then use this data to develop an evidence-based protocol to safely manage these kids, and then evaluate potential savings based on our analysis. So this was a retrospective study from 2009 to 2015. We ended up finding 250 patients who underwent non-operative management of lateral humeral condyle fractures. We then looked at the number of visits, cast, and x-rays these children received and their outcomes. The table at the top shows the variation in just this one center. So this is a large pediatric center. It had 15 attendings and 12 APPs treating these kids. And just to briefly take you through it, the first column is the number of visits, followed by number of x-rays, and then number of casts. And you can see the average at the top, but the range is huge. So 1 to 5 visits in 4 weeks, 2 to 31 x-rays in 4 weeks, and 1 to 4 casts, all in a very short time period. And put another way, on the bottom left-hand side of the screen, the number of casts they had between 1, 2, 3, and 4 is very variable, as well as the number of times they were brought back for follow-up on the right side of the screen. The cast status for x-ray has also not been defined, so some practitioners are getting the x-rays in a cast, some out, some in the cast and taking them out for further imaging. There's really no set protocol for this. The number of x-rays was also all over the map, although 4 views was the most common. And so the outcomes for these kids, of the 250 patients we followed, only 3 ended up needing surgery. So 3 displaced beyond the 2 millimeter mark that we would recommend operative intervention, and this was caught at days 9, 12, and 15. All of these kids then underwent a successful open or closed reduction along with percutaneous pinning and regained full range of motion by the end of their treatment course. We then conducted a literature review to see how our data stacked up against what's been previously reported. Our study is on the bottom line of the screen. First, I just want to draw your attention to the first column, the number of patients. We had 250, which was significantly more than what has been studied thus far. And then in the red box is the amount of displacement when these kids were followed over time. Again, we started this by saying that it is very variable, and we also wanted to know when they were displacing to kind of guide our treatment on when we needed to see them back. So ours were 9, 12, and 15 days, and in all of these studies, they were between 7 and 14 days. So with this information, we have the following protocol. These kids need to be seen as soon as possible for appropriate diagnosis and immobilization. And this just needs to be under the supervision of a pediatric orthopedic provider. So this can be in the ER if that's in a setting where residents are staffing this with attendings who are pediatric orthopedic surgeons, not necessarily in the clinic. They can then be seen in 10 to 15 days with their first cast change, and we think this is sufficient to catch those late displacers. They can then be seen in 4 to 6 weeks to evaluate for radiographic healing and removal of their cast. At our center, casts cost $712, that's at least the charge, and a set of elbow radiographs are $460. So with our protocol and our average number of visits, this would eliminate 2 visits, eliminate 1 cast change, and 2 sets of x-rays. So this would lead to a total savings of $1,632 and 108 minutes per family. So in conclusion, displacement in the appropriately selected lateral humeral condyle fractures treated non-operatively is relatively rare. We had 1.2% in the largest series of these patients. And our optimal proposed follow-up at around the 10 to 15 day mark is not only sufficient, it's safe, it saves money, and results in a better value-based care system for these kids.